Yeah? Oh, there you go. Okay, no, quite all right. So, hi, everyone. We have a small group here in the bistro, but we also have people streaming this event virtually. So, hello to everyone, both virtually and in person. Thank you so much for taking time out of your very busy days to participate in this event. We're very excited to present this panel to you. Some time ago, my name, by the way, is Annie Chandy. I'm the head of diversity, equity, and inclusion here at Ferring Pharmaceuticals. And some time ago, the wellness team here at Ferring sent out a survey to all of you asking you all what you are interested in. And one of the things that came back loud and clear from everyone who participated in the survey was that they felt like there was a lot of offerings for people who are in the parenting stage of life, but there were not as many offerings for people in other stages of life. So this event is really an answer to that question. You asked and we answered. So we're here to give you information about all of the different stages in the journey of a woman's health, postpartum, until forever. And so we're very excited to be presenting this in partnership with the Diversity Advisory Council, the Ferring Women's Council, and other teams here at the Ferring Pharmaceuticals Company to give you the information you need to navigate through all the different challenges that you may face during the course of your journey as a woman and as an ally to women over the course of your lives. We're happy to do this, especially now in Women's Health Month. So without further delay, I'm going to introduce our panel that's going to be presenting some information for you to hear today. Our primary partner in this endeavor was Dr. Somi Javaid. She is from HerMD and her team at HerMD. Dr. Javaid is a board-certified OBGYN, leading women's sexual health thought leader and menopause advocate. She's the founder and chief medical officer of HerMD, a team on a mission to make women's healthcare exceptional by educating, advocating for, and empowering patients to take control of their health concerns. Dr. Javaid was most recently named one of Inc. Female Founders 250 honorees and has been featured in Forbes, Vogue, Well and Good, In Style, Parents, Refinery 29, Mashable, Adweek, and Pop Sugar. In August 2020, Dr. Javaid spoke about gender bias and the female sexual health revolution on the TEDx main stage. And in January 2021, she was featured in Women on Top for her work as a trailblazer and pioneer in women's sexual health. Thank you, Dr. Javaid. We are so fortunate to have you here today, and we're looking forward to hearing what you have to say on this very important topic. I would be remiss if I did not mention, as we were talking about HerMD and all the work they do, if I didn't mention Kamal Caruso, who's here. Kamal, where are you? There you are. Kamal put a lot of effort into helping us put this event together. We had lunch one day, and from that lunch was born this event. And without her, this wouldn't have happened. So you're very lucky to have her on your team. She does a wealth of work to support you, and she's been a great partner to us as well. So thank you so much. Also here to address your health, nutrition, and fitness-related questions is Callie Exas. Callie is a licensed registered dietitian, nutritionist specializing in women's health and well-being. In addition to her MS in clinical nutrition, she holds a master's of public health from NYU and has over 10 years of experience supporting women as they move through the different seasons of their lives, from fertility to pregnancy, postpartum, and beyond. In her work, Callie's mission is to empower women by taking a deeper dive into the biological, physiological, and psychological components of her clients' nutrition and self-care practices. Callie guides her clients to help them better understand how to work with their body and become their own best advocates for more energy, optimal hormonal and metabolic health, and body confidence. Callie has been featured in the Huffington Post, U.S. News, the 30, Insider, Healthline, Elite Daily, and the Hormonally Yours podcast. Thank you so much, Callie, for bringing your expertise to Ferring as well. Last, but definitely not least, is our very own Dr. Elizabeth Garner, who is our Chief Medical Officer here in the U.S., Chief Scientific Officer here in the U.S. for Ferring Pharmaceuticals, and she's going to be moderating this event for us today. As you all know, Dr. Garner has nearly 30 years of experience in medicine and industry. She has a medical degree from Harvard Medical School and a master's degree in public health from Harvard School of Public Health. The list of her honors and awards are really too numerous to mention. Since you all know her, I'm not going to do that, so please join me in welcoming this extraordinary panel to this discussion. So I'm going to hand it to Dr. Garner. Thank you.
Thank you, Annie. And do we not have an amazing panel today? Incredible. So let's get started. I'm really excited about this discussion. Menopause in particular is not something we tend to talk about at work, right? So this, I think, is going to be very helpful for the folks who are here and as well for the folks who are online today. So let's start just with a definition. Like, what is menopause anyway? And more so, what is perimenopause and postmenopause? Like, what is that?
I don't know. I didn't learn about it in medical school. I'm joking.
Good point.
It's 12 consecutive months with no cycles, but some of us may not have a uterus or have had an ablation, so it's an elevated FSH, low estrogen levels.
And what's FSH, sorry?
Follicular stimulating hormone. Average age is 51. Perimenopause, the years preceding, can last up to 10 years. That's the definition.
And then what's postmenopause?
Yeah,
what does that
so
mean?
people think, oh, I'm done. I'm not symptomatic. I think clinically we just use it to determine whether or not people are bleeding or not and define, because once you're menopausal, you should not have any bleeding. Perimenopause, you can bleed, and that's a distinction that we need to make.
Okay, and then in the perimenopause, I think if I can remember, often there may be bleeding, but it can be very irregular too, right?
It can be completely regular or irregular.
Okay, and then but postmenopause, or once you've passed that year of, you should really never be bleeding.
You should not have bleeding.
Right.
You shouldn't. Sometimes it's a side effect of hormone therapy, but you should not have bleeding. It's not normal.
Right, yeah. Okay, thank you so much. So can you tell me a little bit more about sort of what's actually happening in the body during menopause, right? You talked about the hormones and so on, but can you tell us a little bit more about sort of like there's estrogen, there's progesterone, there's testosterone, like what's happening with all of those?
Yeah, so all of our hormones are produced mostly in our ovaries, and those levels start to go down. And as they start to go down, it's like going through withdrawal. Your body's used to like these high levels, and all of a sudden you're down here. And estrogen affects us from head to toe. And so I call menopause estrogen withdrawal. Like if you were used to 6 cups of caffeine, and all of a sudden you're on 0, and people are like, just grin and bear it, I mean, that's crazy. And so that's what menopause is, just withdrawal of estrogen, progesterone, and yes, women do make testosterone. Mm-hmm. Testosterone is vital for sexual function for us, for muscle mass. We don't have as much data as in women for testosterone, but definitely the global consensus statement and menopause societies support testosterone use in women.
Excellent. Thank you so much. And then just one more question about it. Does menopause end?
I mean, we spend 40% of our lives in menopause, so it's a state.
Okay.
It ends, I heard someone say this once, when you die, that's when menopause ends, right? I mean, that's when it ends. But that doesn't mean you're going to be symptomatic. So that's the
Right.
distinct
Right.
difference.
Yeah.
Right? Once you're menopausal, you're menopausal.
Yeah. Okay, that's helpful. Anything to add there, Callie?
Well, yeah, I would say going back to like what's happening in the body as these hormones decline, these have other ramifications from an inflammation state, right? So estrogen is a neurotransmitter modulator. It reduces inflammation, but it also plays an integral role with like metabolic function and your mental health. So as estrogen declines and all these other hormones kind of decline, all of these symptoms and other systems in the body are impacted. So it's a whole body thing. It's a whole brain thing, and it's real.
That's great, and that's a perfect segue because we're going to talk about a few of the issues that women deal with, right, during the perimenopause, menopause, postmenopause. So how about we start with changes in the body, right? What happens? We know that women's often in perimenopause start being concerned about weight issues and, gosh, I could eat whatever I wanted and what is happening here. So can you talk about some of the changes that happen to the body? Either one of you first.
I mean, hot flashes, insomnia, night sweats, loss of sex drive, painful sex, vaginal dryness, recurrent urinary tract infections, joint pain, frozen shoulder, like you said, weight gain, but weight gain particularly in the middle region. So not only do women notice a change on the scale with the number, their body shape, they say, is very different. Whereas in our reproductive years, when we're having babies, we may put on weight in our breast or hips when we gain weight. In menopause, we may, and you notice I'm saying may, put weight on in our midsection. Our metabolic rate definitely changes. We start to lose some of our bone density. Our risk of a cardiovascular disease increases. Mood disorders, like you were talking about, we see a spike in anxiety and depression. Cognitive issues, so mild cognitive decline, like word finding is an issue. People talk to me about leaving their cell phone in the fridge, forgetting their kids' names. And I use the words very carefully, mild cognitive decline, because if it's something more severe, I want to make sure people understand there may be something else going on.
Right.
And so those are just some of the symptoms. You talk to experts and they say there's 34 symptoms. I was listening to someone this morning and they said, no, there's actually 50 documented symptoms now. And so head to toe, there are symptoms of menopause that can impact you. And I think the thing that's so scary is, like, Oprah was misdiagnosed over and over again. And the reason I bring her up as an example is she's educated, had insurance, had means, and her palpitations were one of her signs of menopause. And so it can present very differently in each individual. And so that, along with the fact that doctors are not regularly trained in menopause, renders great delays in diagnosis.
Right. Thank you.
I just want to add too, like, I am 40 and I'm also 1 year postpartum. So everything that Somi just described, I'm like, am I postpartum or am I perimenopausal or am I dying? What's happening to me? So it can be really nuanced and confusing. And I think your health state to begin with can really determine the symptom manifestation of how you move through this season in your life, for sure.
Yeah, that's very helpful. And it's no surprise given the magnitude of, the numbers of different things that can happen and random symptoms that you would never necessarily associate with menopause. It's clear why sometimes women are just exactly what you said. What is happening to me? I mean, am I dying or something? So, and the fact that, there aren't many physicians who truly understand especially across the full breadth of menopause, right? An OBGYN might understand the bleeding thing, but they may not have any idea about palpitations and things like that, right? So that can be challenging.
Yeah, putting that whole picture together.
Right, exactly.
I mean, I didn't, and people who hear this story think it's hysterical, but I love being as transparent as I can. My first 3 hot flashes, I did not know what was going on because they are not as they're written or described in the medical textbooks. I woke up in a cold sweat, yeah, that part, but feeling very anxious, and my heart was racing. And my girls were away at camp, and and there was no communication. You weren't allowed to call them. So I assumed I was anxious because they were gone. And I started sweating, and I'm a girl who normally doesn't sweat. And so my husband's like, your hair is wet. And so the third time I was like, oh my God. These are the hot flashes that I've been diagnosing and treating for 20 years. I'm like, who wrote the word mild? Let me find that author. You hear a lot of stories of even medical professionals and those of us who are trained who don't recognize the symptoms within ourselves because it's not been accurately described or taught to us. It was pretty eye-opening.
Yeah, and myself, I mean, I had and do have here and there palpitations. Took me ages to be like, oh, wait, I think it's connected in some way, right? Yeah, so, and an OBGYN as well. So.
Well, and also, if you are a cycling woman, and we know that during your luteal phase leading up to your period, as estrogen declines, this is when PMDD or increased anxiety, these symptoms do manifest for many women in that particular phase of their menstrual cycle. And so it's nuanced again, and it's kind of sneaky in the way it comes up because you think, is this normal? Am I normal? I think this is part of the normal thing, but it then becomes not normal for you.
Right. So can you talk to us a little bit more in depth on some of the specific sort of conditions? So I'm thinking about bone health, brain health, and heart health. If you could just go a little deeper into each of those. Go ahead.
So bone health, we lose a great deal of our bone mass as we go into menopause. And so that doesn't mean we're destined to break our bones and fall and break our hips and die. Strength training, calcium, vitamin D, hormone therapy can be a nice option, but strength training is really, really important to help us, weight-bearing exercise. And so we really want to start paying attention to our bones actually before we go into menopause. As far as our cardiovascular risk, Kamel and I started our company because we nearly lost our mother at the age of 45 to cardiovascular disease. And her chest pain, left arm pain, and shortness of breath was dismissed as too much caffeine and child stress. Yes, we were insured and we lived in Cleveland, Ohio, but there wasn't data to support why a thin, non-smoking woman would ever present with four-vessel disease, right? So that's why I went into, my career was catapulted into being such an advocate for women. Mm-hmm. But we know that estrogen, the way I describe it, is our arteries are like a tube. And so we know, or we theorize, that estrogen lays down a protective lining so that cholesterol can't build up. And so as we go into menopause, our risk of cardiovascular disease increases and we start to mirror the risk of like men. And so if we get on hormones early enough, within the first 10 years, if you guys hear about the hormone window or the menopause window, that's where the data supports that actually cardiovascular risk decreases with hormone therapy. And then exercise can also reverse some of that damage and make increase the elasticity of our vessels and make them less stiff. And so that's where cardiovascular exercise, or cardio, is important. So at this point in your life, you need to do both strength training and cardio. And then the third thing you asked me, and then brain, yes. So for the mild cognitive decline, there are lifestyle things that we can do, things that require hand-eye coordination. Reading can help. People who are active and busy, they have healthier brains. Getting sleep, that's when our brain repairs itself. And the other thing is hormones do support brain health. We know this. I've been hearing a lot about Alzheimer's disease and how 2/3 of Alzheimer's cases are actually women. We have proven that changes in the brain are not just due to aging, but actually due to menopause. So lack of estrogen does negatively impact our brain. So for some women, hormone therapy does help with cognitive function.
Thank you. So informative. Amazing. Callie, I'm sure you have some stuff to add to that.
Yeah, I mean, certainly. So I think the biggest thing really when it comes to vitality and maintaining longevity and making sure that you're thriving in your life into this season is really the biggest thing that I see is strength training. Not enough women are strength training in a way that actually, and eating, in a way that actually supports building muscle mass. So that means balancing your blood sugar. It means consistently eating throughout the day. It means making sure that you're eating adequate protein, but also it means lifting heavy weights. I know so many women, there's this stigma around actually lifting big, heavy weights, doing squats, deadlifts, those big power build lifting moves. Lots of women come to me and they're like, I want to change my body, but I don't want to get bulky. You're not. You will not get bulky. But it's so important to actually do those types of functional strength training movements so that you are building muscle mass and maintaining the muscle mass that you have, so that you can increase the way that or optimize the way that your body can use and make and store energy, which is muscle mass is where it's at. So maybe less Pilates, more squats and deadlifts, please.
I love that. Talk a little bit about what we were discussing the other day around diet culture.
Diet culture, yes. So at any stage, I think it's important to recognize that women are, there's so much socially ingrained in the way we eat and move and our relationship with our bodies. We are actively taught to disassociate from our body's needs through diet culture. And so understanding actually what your body needs can help you kind of tune out the noise and be your own best advocate when it comes to your nutrition and your self-care practices, but also how you approach being an advocate for yourself. I think diet culture, it starts for so many women at such a young age, and it's interesting that we're talking about perimenopause and the body changes that happen during perimenopause and into menopause and how women struggle with that. But I kind of think that it goes back into puberty where lots of girls, when they're starting puberty, they have this growth spurt and maybe there's some weight gain there and it's stigmatized and we're taught that it's our fault and you have to go clothes shopping because your clothes don't fit anymore, but your body is doing something very normal. We're just not told that it's acceptable that bodies change. And we can respect our bodies and come at these changes from a neutral place versus a judgmental place and still be advocates for our health and our well-being. And how that can actually heal our relationship with our body first and foremost.
Fantastic. And can you talk a little bit more maybe around just nutrition as well, right, as the perimenopause years begin?
Sure. So as we've said before, your bodies change, and that means your needs might change, right? What I see most often in my practice is what women are turning to in their perimenopause years is what worked for them before in terms of maybe restriction or going on some detox or, doing what their neighbor Karen did or even trying like something like Optavia, which please don't. So if you've heard of Optavia, bad news, bad. Don't do it. But so when it comes to this place in your season of life, I think it's really important to really understand blood sugar balance, and the importance of your eating practices, not just what you're eating, what's good versus bad, but also the practices around your eating. So maintaining a regular eating schedule, making sure that your plate is balanced with protein, starchy carbohydrate, and your fruits and vegetables, making sure that the base of your meal, most of your meals, it's not going to be perfection. Life happens in the gray. So, we have to be flexible in that, but most of your meals include half of your plate being fruits and vegetables, and trying your best to include whole grains. And then from there, being able to enjoy your food as well. When it comes to blood sugar balance, additionally, I think it's really important to know your protein needs. I'm going to tell you a little secret. It's more than what you think it is. I usually, for perimenopause and even postpartum women, go with 0.8 grams per pound. And then from there, yeah, it's a lot more than you think it is. At least aiming for the range of, if you're not getting that, range around 100 grams per day of protein. Most women are not getting that, and when I tell them that number, they get a little scared. But it's easy. It's actually easy to do. And we can have a whole discussion on that. But and then on top of that, making sure that you're getting healthy fats in from unsaturated fats. So like avocados, cold water fatty fish, maybe supplementing with fish oil. I really love nuts and seeds. Phytoestrogens from flax meal are wonderful. Edamame, another great source of phytoestrogens that help mimic estrogen in the body. And then as well as fiber, making sure you're getting around 28 to 30 grams of fiber a day. If you're doing like low carb or keto, that is going to impact your fiber intake. And that impacts your gut health. It impacts how your body processes certain hormones. And it also helps reduce inflammation. So making sure that you're getting adequate fiber, adequate protein, some healthy fats in your day-to-day, and then adding lots of color to your plate. I love to tell my clients, aim for 3 colors on your plate and make it a little game. Maybe try to eat the rainbow. Simplifying it that way. But then including foods that you enjoy. How many of us are like, I'm going to be really good. It's Diet Starts Monday. I'm going to be really good this week. I'm only going to eat this. And then by Friday, you're like, oh my God, I need a margarita and a burger. So being able to include those fun foods will help you make mindful choices. And you should enjoy your food. It's really important that we're able to enjoy those things. Food is a great joy. It's a social thing. It's a cultural thing. So we should be able to come at it from the gray, from a flexible mindset.
I love your message of not self-loathing. We've noticed at HerMD, 80% of women want to engage in some type of weight loss, weight management kind of program and want that diet culture. But I always give the story of the menopausal mice. Remember they took 2 sets of mice, injected 1 set with FSH. FSH is really high in menopause. So they made them menopausal, and the other group wasn't. They fed them and exercised them the same way. All the menopausal mice became obese. So I'm like, there are some things going on in your body, and that's why things don't work the way they used to. And there was new data about GLP-1s and women who are on hormone therapy, and it works better for those women. So we know something is going on with hormones negatively impacting weight. So I just want women to take that blame and off of themselves.
Yeah.
So important. Such a strong message.
Yes, absolutely. Take the blame off yourself. And I think and now I'm forgetting what I wanted to say.
It'll come back.
It'll come back to me. Keep going.
It will.
But the self-loathing aspect, I think you can come at it from a body respect. Body image in and of itself, that's like a feeling. They pass. You can have a bad body image moment. You can have a bad body image day, but you can always come at your relationship with your body with respect. It doesn't have to be from a judgmental place because it's dynamic.
Amazing advice. All right, let's.
I know. What I was
Oh,
gonna
please,
say.
yes, go.
Yes.
Go.
Okay.
Go.
So,
Yes.
And now so actually, like Somi was saying, so the other thing about diets and coming at it from a very diet perspective is that what we have seen is that weight cycling is actually more inflammatory to the body than even being in a consistent overweight state. So the last thing you don't want to do is go on this diet and then go back off and gain the weight back and then keep going in this yo-yo place. You're making yourself crazy, but also it's damaging to your health and your well-being. It puts you into a more inflammatory state, and also it makes your metabolism even slower because women's hormones are very much tied to their appetite hormones. And so if you're starving yourself, this is going to be a double whammy for you in terms of your metabolic function. We're not small men. Our hormones really do play a huge role in our metabolic function. And so even with like the studies that come out when it comes to intermittent fasting or keto or I don't know, what are the people saying these days? Carnivore diet? I have no idea. Well, I should have an idea, but I know paleo. Yes. All of these studies have been done on men.
Surprise, surprise.
Yeah, and so the science isn't really great in terms of dieting and women's health and especially their hormone health.
And
So-
please don't compare yourself if you have a male partner. Please don't compare yourself to your male partner. I get so many stories of women saying that they did the same diet as their partner and they're down 20 pounds and they've lost nothing and then they're ready to murder their significant other. So very unsuccessful on, in numerous ways. So don't compare yourself because hormones play such a pivotal role for us when it comes to weight and metabolism, body shape, all of that.
Yep. Intermittent fasting. Also, I see often like partners doing it together, but it actually can be really detrimental to women's hormone regulation and insulin function and sleep and mood. And nobody wants to be around a hangry monster. And I know that when I'm hangry, it's not a good scene for anybody. Everybody pays. So there's that.
I'm so glad you remembered that last point. Really, really important. All right, let's go on to another common issue, the pelvic floor. First of all, what is that anyway? I get a lot of questions about that. But how is it impacted after childbirth and certainly into menopause?
So I'll talk a little bit about it and the research we've done, but it's the hammock of muscles surrounding our vaginal opening, our urethra, our rectum. So basically holds things in when we don't want to go to the bathroom, when we don't want to urinate, when we don't want to pass gas at Ferring around all of our teammates. But then also relaxation allows intercourse, to place a tampon, to have an exam, right? So you need a pelvic floor that is very healthy. Healthy pelvic floor also allows us to have great orgasms. And so pelvic floor health is very important to a lot of vital functions for us. We just presented data using electrical muscle stimulation, radiofrequency, microneedling, and had 90 to 95% success rates with incontinence and pelvic floor health. So we're very excited about that at HerMD.
So this is something that I often see not necessarily in my practice, but women struggling with. And being a postpartum woman myself, this is something that I was very passionate about during both of my pregnancies. Pelvic floor is kind of where everything kind of stabilizes from there, from your core function. Even there's neurotransmitters going on in there, posture, pain. So it's really, I think, important to understand kind of where those muscles are, and especially postpartum and into perimenopause, what you want to be able to do is understand how to activate them and regulate their function. And one of the biggest things you can do to pay attention or support your pelvic floor is breath work. So if we all just sit up nice and straight, how many of us often hold our breath and squeeze our glutes? all the time. You probably don't even know you're a butt clencher. If you're a stressed out person, you're probably a butt clencher. And so when that happens, it actually creates an overactive pelvic floor, which can be just as inflammatory in some cases. But if you think about the way your abs work and the way like they knit together, you want to inhale and expand your rib cage out and forward. And then when you exhale, you can actually knit your abs together, pull your belly button into your spine, and you'll feel those lower, very deep abs engage. So try it out here. And then as you breathe out through your nose, feel your abs kind of knitting together, pulling them in, and then that belly button comes in, and then kind of like when your pelvis is going to kind of like tip and turn toward your ribs, and that is where those ab muscles are, and that's how you kind of activate them so you can feel them. And I think the other thing is when it comes to pelvic floor and pelvic floor function is like being able to, again, activate from that tipping pelvic tilt position. You don't have to do crazy like ab moves to activate your pelvic floor. It's really about even like bringing your legs up in like a bent flat position. They're gentle movements, but it can make a huge difference in terms of continence, pain, lower back pain, even like glute pain down your legs. So definitely something that I'm a huge advocate of. I incorporate a lot of the movements and the breath work into my practice, and not hard to do. So even if you're just sitting watching TV and doing some breath work of in and out, that's you're working on your pelvic floor there.
There are at-home wands that you can learn how to use, so that's part of the femtech movement. There's a great company called Origin. They're in a lot of states now. They do it online. I mean, they teach you what to do for pelvic floor physical therapy, and then Columbia University is actually launching a lab because there are, I forgot how many more pelvic floor injuries due to childbirth, due to problems in menopause, and the tissues getting weaker and the muscles getting weaker. But we spend so much more on sports injuries and rehab. And I love sports, but we don't pay enough attention to our pelvic floor health, and it is so integral to life functioning. But pelvic floor physical therapy, and if you're like, that's not for me, online, the wand, like I was talking about, the procedure we do, sometimes giving people hormones will help them. But it's kind of like the Goldilocks story. You don't want it too hot, you don't want it too cold, so you don't want your pelvic floor to be hypertonic or too tight, and you also don't want it to be too lax or loose. And so you need like just the right amount of tone to be able to function.
Yeah. Mm-hmm.
Very helpful. Let's move on to another issue, which we've touched on, but I'd love to hear some more around mental health and how menopause impacts our mental health, strategies women can use to manage symptoms. So please.
I mean, the most common symptoms I see are anxiety and depression, and there were just headlines talking about how it skyrockets in the perimenopausal and menopausal period, and we think it's this withdrawal from hormone, just like we see it in the postpartum period. We know when the WHI came out, that study where everyone stopped prescribing, stopped taking, we saw hormone prescriptions going down. But you know what we saw? Skyrocketing treatment for anxiety and depression, because all of a sudden, all of these patients were left without their hormones. And so I'm not saying you can't have anxiety and depression independently, but definitely can worsen or be diagnosed in the perimenopausal, menopausal period. Some of it's due to lack of sleep, or maybe lack of sexual desire, or just the changes that are going on and you don't understand. But it definitely presents itself. So do the things that you love, try to get good sleep, try to mitigate stress, counseling, And a lot of times I do prescribe hormones if people don't want that. I tell them exercise, yoga, get outside, all the lifestyle changes that you can make, clean eating, therapy. Sometimes they have to see a psychiatrist. It just depends. But there are some great online resources. Talkspace is a really easy way to get into a therapist. They're highly regarded. So there's everyone's treatment plan should be curated for them.
Absolutely. I think like an individualized approach is always the best approach. I would add like a supportive community, people who you can reach out to that maybe understand of what you're going through or can validate your experience. And also energetic boundaries. So knowing what you have the capacity for on your plate and being cognizant of what's going to be too much. And I think women at all stages probably deal with this in some degree, but I want to say this is a time when your bullshit threshold is a lot lower. And so really just knowing that and saying, I have enough on my plate. I can't do this birthday party this weekend or something like that. The other thing I think is really important to mention is alcohol intake is not probably helpful during this time. I would love to tell you to have a glass of wine, but that might not be it for you right now. And so making sure you're getting that sleep is way more important. Limiting alcohol. As women age, their alcohol dehydrogenase, which is the enzyme that breaks down alcohol, women have less of it than men anyway, but you stop kind of making it as in the same quantity. So that means it's harder for you to break down alcohol, which means it affects you even more, which can increase anxiety. So things like that, where just knowing your triggers, having people around you to support you, and knowing what your threshold or capacity is going to help you mitigate some of that mood, anxiety, depression, burnout feeling.
Very helpful. Thank you. All right, so one more issue to talk about, and then we'll go on to talking about the workplace. So talk about the impact of menopause on sexual health and wellness.
Yeah, so many times with women, we think that sexual health has to do with contraception or diagnosing and treating STI or fertility, but it's so much more than that. We have 26 medications to address male sexuality and 2 for women. And so when we're talking about women's sexual health, we need to address things like pain, lubrication, moisture, orgasm, arousal. And the reason it's so important is our sexual health is healthcare. And women who are having sex are more likely to not be depressed, to have better vital signs, to maintain their relationships, to have better work performance, and to be more confident. It affects our mental health. So by not treating women with their sexual health, we're not treating their health care.
Callie?
What she said. Yeah.
Fully agree, 100%. And I believe there's something coming up on that topic.
Hopefully, if all goes as planned, we're going to have a part 2 of this seminar that's focused on sexual health issues in June, we think.
Excellent. Outstanding. All right, so let's talk about the workplace a little bit and the toll, really, that menopause has on women in the workplace. Can you speak to some of that information?
Yeah, so we're going to spend 40% of our lives in menopause. We're usually hitting menopause at the peak of our careers. And yet in the UK, we saw 900,000 women leave the workforce because of undiagnosed, untreated menopausal symptoms. Last year in the United States, the female workforce lost $1.8 billion due to lost productivity, because when you're hot flashing and there's not a cooling room, when you have genitourinary syndrome of menopause, so that's the collective symptoms we can get in our vagina and our bladder. So vaginal dryness, sexual pain, incontinence, frequent urinary tract infections, which can lead to death and hospitalization. And there's not a nearby restroom, women will skip work. When you have brain fog or word finding and you have big presentation, you don't want to go in. And so we are not retaining our top talent. We're losing them. It's costing us billions of dollars at the prime of our careers. And so the physical, emotional cost and the fiscal cost of not treating menopause, perimenopause is too great for employers and for patients alike.
And in your own practice, are you hearing about this as well? There's the data, right? The articles that have come up, which are incredibly helpful and like helping us to understand the burden. But what about on your day-to-day, right? How much are you hearing from your patients?
All the time. And I have women who go on hormone therapy for that reason so they can continue to work. They may not have the insomnia, they may not have the other issues, but I have women who literally will come in wrapped with a towel, like a cold towel around their neck and a fan. I have women who work in broadcasting or in the TV industry, and they say the lights trigger it. And if you don't fix this, Dr. Javaid, I'm going to be unemployed, because the minute those lights go on, I start sweating profusely. It ruins my makeup. I can't be on TV. And so it is very, very distressing for patients who are trying to work, who need to work, who want to work. But then they're like, we can't talk about menopause at work. Like, why? It's a life stage. We need to eradicate the stigma and taboo. There's lactating rooms, if you think about it, and there should be, but that's this much of our life stage, right? But 40% of our life we're not addressing in the workplace, and we're losing individuals, and we're losing money and satisfaction. Like, it's crazy to me to not address it in the workplace.
What do you see, Callie?
I see women really struggling with, again, their relationship with their body and kind of like the body confidence side of things, but also in my practice, I see a lot actually having to do with brain fog. They come to me exhausted all the time. I'm tired all the time. It doesn't matter how much sleep I get. I hear often that ADD symptoms, like the neurotransmitter symptoms, are really detrimental. And so when you feel like you're constantly having things thrown at your face and you can't process, it's really disorienting for these women who are used to being able to make sense of things and process. So that's something that I see all the time. And I think, again, as Somi said, like, it's just unfair that women spend so much of their early profession also in their rearing years. And so finally, when we can get to a place where we have the mental capacity or the physical capacity or even the scheduling capacity to get going in our career, it feels like it's being taken away from us. And that's a mental struggle. That's really hard and not fair. And there should be support, for sure.
Yeah, women feel like they're losing their jobs and their relationships because of menopause. I was giving a lecture once, and I had a male investor who was in the room, and he was like, oh my God, I lost my marriage because of GSM. And no one talked about it in the workplace. I had no idea. His wife was having sexual pain and low libido, and he assumed it was just rejection. And he had no idea. And so to hear patient stories every day about losing their jobs or having to make that choice because they don't feel good about the work product they're putting out there, or they're missing too much work because they're going from doctor to doctor to doctor and not getting a diagnosis, or hearing, oh, we don't do hormones here, which is also eye-opening to me that there's still doctors in 2024 saying that to patients. It's really sad because it's avoidable and treatable.
Wow. So beyond hormones, because we all know that the power, right, of hormones to change many of the things we've been discussing today. But despite that, there are a lot of women who are still anxious and nervous about using hormones, right? So what other solutions, you've talked about some of them, but can you sort of name a few really sort of top things that you would recommend?
Yes, but before you get scared about hormones, there were a lot of headlines today about hormone therapy. There's observational data about using it in the perimenopausal period. There was an article last week about positive benefits even after 65. I mean, we know it's best started in the first 10 years of menopause. And then literally, I don't know if you guys saw the headlines today. So remember when WHI came out, it was like hormones are dangerous, hormones are bad, hormones cause Alzheimer's, cancer, heart attacks. And then literally an article came out today. Kamal, what was the headline? Do you remember? It was hormones are now safe or... hormones are killing you. Basically, was the headline. Yes. When the WHI data came out, and then today it was like hormones are safe. Hormones are safe. It wasn't a new study. It was just a different analysis of the same data and a different way to write up the article. That is it. It wasn't all of a sudden a new study. That should make all of you, men and women, very, very angry because we misled you for a very long time. So now I'm off my soapbox. Let me talk about the alternative therapies real quick. So there are a couple of FDA-approved medications that are non-hormonal for hot flashes. I don't work for any of these companies, Veoza and Brisdell. Off-label, doctors can use high blood pressure medications, gabapentin, antidepressants, counseling, therapy, yoga, acupuncture, avoiding stress. That can help with hot flashes. Cognitive behavioral therapy for sleep, pelvic floor physical therapy we mentioned. Localized hormone, different, moisturizers, lubricants. There are 2 FDA-approved medications for low libido, Addyi and Vyleesi, both non-hormonal. I mentioned the procedures that we do. So there are so many treatment options beyond hormones, depending on what symptoms. Oh, for bone health, the bisphosphonates, strength training, cardiovascular, protection. We talked about exercise. There's the statins. I mean, it just depends on what symptom of menopause, perimenopause you want to treat.
It's unfortunate that most physicians don't know much of what you just described. So I think it's really important to really seek out experts such as you and you, to talk about this stuff, right? So just a pointer there. So I think we have just a few more minutes, trying to figure out which topic to... Let's talk a little bit about social media, actually, because you've already mentioned kind of the stigma thing, and that's a big issue. But around information and where people are getting information right now, and just can you speak to that and what your experience is for both of you?
Yeah, I have seen so much, misinformation especially in my field, nutrition, right? So that is a huge problem. But I think the bigger problem is when it comes to women's hormonal health and especially around perimenopause, is why are women actually having to turn to social media for information on a life stage that half of the population goes through at some point. That is the major issue. And so with social media, I think it's really important to make sure that you are following credentialed experts that can still speak to nuance. And then from there, I think protect yourself. If someone is posting stuff that doesn't make you feel good about your body or it doesn't jive with your values, then please unfollow them. There is no right way to do this. So you have to figure out what feels good for you in your body, because only you know what it feels like to be in your body. And from there, be your own best advocate when it comes to getting the support team that you can put in place yourself. It's kind of like dating. At the end of the day, this is all a service-based industry. So shop around, date around. It's okay to find the people and the support team that works best for you within your values. But when it comes to social media, I don't think the problem isn't that women are turning to social media. The problem is why they're turning to social media. They're not getting the answers that they need around their body from women that came before them, or from their providers, or from their community. So that's the major issue.
I mean, we're graduating 93% of our medical residents with zero knowledge of menopause, where we're going to spend 40%, 93%. And 10 years ago, they estimated 20% of OBGYNs are trained in menopause and sexual health care, and in a decade, we've gotten to 31%.
That's OBGYNs.
OBGYNs who learn about this. Or practice bikini medicine, as we heard yesterday, right? The parts of the body that are covered by a bikini. There are a couple of social media sites that I actually love that are direct to consumer that aren't trying to sell you a product. Peri is one, Perry. Peanut is another. The Swell is another. And then some of the companies that do sell products, they do have independent educational sites where they get experts like me who will write a blog or write something for them. And it's just information. It's not about selling you a product. There are some great doctors in this space who are very visible on social media. Menopause Society is a great place to start. Look it up. Your zip code, you can find doctors that way that are certified and true experts. The International Society for the Study of Women's Sexual Health would do the same thing if it's a sexual health issue that you're experiencing. So there's some great, I agree with you, some horrible issues on social media. If someone is just trying to sell you something, or they come out anti-hormone or bashing an optionality that you may actually like, I would be very weary. A lot of times those people want to bash that because they want to sell you what they can offer. And so just be a very, very smart consumer. It's very sad to me that there's a lot of opportunistic people out there right now.
Very, very helpful. All right, we have like 2 more minutes. So I just want each of you, if there's anything else you'd love to say to this audience, anything we've missed.
HerMD is having a great event May 8th at Luminary in New York City. We have, 30-some experts who are going to be there talking about all things women's health care. There are still tickets available, so please join us. I will be taking the stage again, along with a lot of my colleagues who are flying in. Please follow us on social media, on Instagram, Facebook, and LinkedIn. And hermd.com.
Yeah. You can find me at womanup.wellness on Instagram. I'm on there. And if you want to follow up, feel free to look me up. Callie at Callie.
I have a feeling there may be some people reaching out to both of you. So.
I will say, being 1 year postpartum, I am now at a stage in my career where I am coming back into things, and I'm excited to be doing more. And so this is, it's a new venture for me as well. So yeah, I'm out there.
Fantastic. Amazing. All right, we have some time for Q&A, I believe. So Kamal, you're going to manage anything that's come on online, and I think Annie was...
Okay, perfect. And then we're going to put up, yes, the QR code. So if anyone wants to scan to ask anonymously, they can. Or we could take live questions. We wanted to do both. All right, here we go.
Thank you. I had so many questions, but I can't remember them now.
That's the brain fog.
I know. No. First, I just want to thank you. This has been very informative. I was supposed to leave for a doctor's appointment, and I'm still sitting here because all this information is so interesting. But I did have a question about the hormone therapy because, of course, you've heard so many cancer links to hormone therapy, and so and then you mentioned this data that was reanalyzed, and now it says the opposite thing. being a scientist most of my life before coming here, I mean, analyzing your data is really, really important. So how do you know that the first analysis wasn't the right one? You know, why did we assume that the second analysis was the right one?
Well, we have a lot of data since then also that didn't come from that initial study. But in the initial study, estrogen only was always proven to decrease your risk of mortality, decrease your risk of breast cancer, and decrease your risk of dying from that breast cancer if you developed breast cancer on the estrogen-only arm. It was the estrogen plus progesterone arm that showed a slight increase of breast cancer. And remember, they studied Prempro and Premarin, which were conjugated, meaning not identical to what's produced in your body, and they studied oral formulations, which we know can have more adverse effect than like a transdermal, like a gel or a spray or a patch. And remember, they studied a large number of women in the 7th decade of life. That's not when most physicians are initiating prescribing hormone therapy.
Okay,
So
thank you for that clarification.
you're welcome.
Any other live questions? We do have a number that came in virtually also. All right, cool.
That was amazing. I took a whole page of notes. I have a lot of research to do now. As somebody who's in human resources, and I read a lot of articles in that space, and I just noticed that menopause all of a sudden seems to have popped as like the thing we all need to be paying attention to and focusing on. What happened? Like, why is it now that this has come up? Because I don't know what the trigger moment was. And I'm just wondering, because first it was mental health, and now, which is still very much a critical part of even the things that we do at Ferring, but now menopause all of a sudden just popped up on the scene, which is great, but I would love to hear your perspectives.
I was just asked this question this morning when we were filming a documentary. I really think it was patient consumer driven and women saying enough is enough. Telling women to just grin and bear it. Sorry, you're doomed to suffer. They were not going to take what generations before took or tolerated, and they shouldn't. And so it was their collective voices over and over again pushing for treatment options, for solutions. And then a few of us who have been trying to change the game in medicine were like, okay, we'll get on. No one ever taught me about social media. No one taught me about marketing myself. And so when we opened the first HerMD and we saw women from 35 states and 3 countries coming to Cincinnati, Ohio, to my little practice, we were like, oh, we're on to something. So I really think this is patient consumer driven. And then you get a couple of celebrities who have become huge allies in the space. And think about how dangerous it is for them to admit that they're menopausal. And then they're still trying to, dance at the Super Bowl halftime show. I don't know if J-Lo is in menopause or not. She's not my patient, not yet at least. But you look at menopause now, and I think women think of Michelle Obama and J-Lo. They're no longer thinking of, I love them, but the Golden Girls. And so I think the optics have also changed on what it means to be menopausal, or is changing. So for me, I think it's really patient driven.
Ditto, yeah. Yes, ditto.
All right, we have a question. As you all are thinking of maybe some here, we have one. Are any of the new weight loss drugs that are on the market effective treatment for menopausal weight gain?
I mean, yes, they are. Is it the only? Should they be used in isolation? I'm a full believer in a full curated treatment plan, not just here's your GLP-1, goodbye. We have to make sure you're a candidate. Is it covered? And it may be in conjunction with hormone therapy, nutritional, support, exercise. But I think a lot of people are just looking for a quick fix. And I worry that they'll pay for the medicine for 6 months, get off of it, and then be in the same issue again. but we do see a lot of women in the menopause and perimenopause space wanting to initiate these medications, and they are effective.
I would agree with that. When with menopause and perimenopause, insulin function changes, GLP-1s act on the insulin receptors to make you more insulin sensitive. So with that, yes, they do work. However, what we're also seeing, especially in my space, is that people who are going off of them regain whatever weight they lost. So it's a long-term medication. It's also something very similar to even bariatric surgery, where if you are not doing the lifestyle practices that are in place, the gains are not sustainable, or you may not even react well with it. It might not work for you. So making sure that you're a candidate is very important. And in order to be an appropriate candidate, I think it's really important to have those lifestyle and nutrition factors in place prior to going on to these medications. And then understanding what those expectations around what these drugs can actually do for you. Sustainable weight loss for long-term health and well-being is 2 and under pounds a week. Slow, sustainable fat loss. We're not talking, because when you have large amounts of weight that you're losing quickly, this is also muscle wasting. And that's actually more detrimental for insulin function, metabolic function, and long-term health than that slow. What you want is that slow weight loss that's sustainable.
I also don't, the opposite, I do not want to shame people that do choose GLP-1s, especially if you are a candidate. I've heard people on social media say, oh, well, she cheated. It's not cheating. It's one of the tools in the toolkit. And so we shouldn't shame people for the opposite as well, for opting to lose weight and to use a GLP-1.
Absolutely. It's a tool in the toolkit. I think that they're an amazing tool, and for so many people who are struggling with insulin function, we know that insulin is blood glucose balance is so important for reducing inflammation and long-term health and cardiovascular disease. So absolutely a very powerful tool, especially in this demographic. It can be really helpful and life-changing for so many people. So we always have to, it's not risk versus reward, it's risk versus risk in that sense. And what's the heavier risk? But also on the other side, like, it's a long-term medication and it requires some foundational pillars of health to be addressed.
So don't Google, how do I lose 10 pounds before my vacation next week? Got it.
Please
I won't
don't
do that
wrap
again.
yourself in saran wrap.
Sweat it out.
Yeah, no, please just dehydrate yourself.
Yeah.
Please don't.
No. If you have had a hysterectomy, is there a definitive way to determine if you are in menopause? And additionally, as I get older, my sexual desire has diminished, even though I am still, let's answer the first one, and then I will get to the second part of that question.
Yeah, so that's what I was alluding to in the beginning. So 12 consecutive months without bleeding, but then there are some women who've had a hysterectomy or an ablation, so we can't rely on that. So that FSH level that I was talking about, elevated, depending on what lab you use, we use LabCorp, so greater than 30 on 2 separate occasions is the definition that we use to declare that you are in menopause, because a lot of women don't want to wait 12 months to have that, especially if they're really symptomatic. So yes, blood testing, I don't support, a lot of agencies don't support, there's like the saliva testing, there's the urine test. Just go get a blood draw that your insurance covers. So yeah, FSH.
Okay. Yeah.
Do you feel like there's a reluctance to do that in OBGYN practices? I just feel like I've asked this question before when I've gone to my OBGYN to try to get a handle on what's happening to my body, and I get reluctance. It seems like there's a reluctance to want to do the blood test or figure it out.
I think a lot of gynecologists were trained the way that I was, just let a patient go 12 consecutive months and then make the diagnosis. Or they'll say, well, what difference is, checking your hormone level is going to do? It's not going to change anything right now. But that's not necessarily the case because you can catch menopause before the 12 months have gone by. But there is reluctance, you are correct. But remember, part of the barrier is the lack of education when it comes to menopause care, or sometimes just lack of time. I was teaching a CME course, and providers are down to 6 to 7 minute appointments, and they're also still trying to deliver babies, and they're up on, all night on call. And so they don't know, or they don't have the time, or they know they can't see you again for another 4 months. So why are they going to draw a blood test when they can't see you for a couple months? But a lot of reluctance to drawing hormone levels. And I think it should be utilized as a data point for patients.
Okay, I got to part 2. I'm almost ready for my readers. Additionally, as I get older, my sexual desire has diminished, even though I'm still very attracted to my spouse. Are there drugs or methods to increase libido in women?
Yes, so it's called hypoactive sexual desire disorder, just like we call impotence ED. Low libido is negative, but yes, so there are 2 FDA-approved medications that insurance usually covers. The first one is called ADDY, ADDYI. It stands for Add Your Interest. Non-hormonal, works on neurotransmitters in the brain. It is not female Viagra. And the reason I say that is it doesn't mean you take it and then all of a sudden you're rearing to go. It takes 6 to 8 months to take effect. And the studies showed that it increased desire, decreased the distress associated with your sexual drive not being where you want it to be, and increase the number of sexually satisfying events. Are there people that don't respond to it? Yes. Are there people that it works for amazingly? Absolutely. It depends on, there's a lot of reasons your desire may be decreasing. It breaks my heart every time I hear I have low desire, I swear I love him or her. Women are always jumping on the defense. Like, I promise you it's not my partner. The second medication is similar to Viagra in that it is an on-demand. You inject yourself. It's called Vyleesi, Vyleesi. You inject yourself 45 minutes before you want to have intercourse. And that is also available. It also works on neurotransmitters in the brain. These are non-hormonal, so a lot of women are candidates for them, but they are prescription. And like I said, they are covered by a lot of insurance plans.
Can you also talk about, sorry, I'm going to not ask a follow-up question, but the non-medication, so things like Rosie or Dipsy, things like that.
Well, and then also testosterone.
Yeah.
So currently in this country, even though there's data and global consensus statement on the support of testosterone use in women, particularly for sexual function, we currently do not have an FDA-approved testosterone-only option for women, but there are other ways to get testosterone. There are some great apps out there and some therapeutics. So Rosie was designed by Dr. Lindsay Harper, and it improves all of the domains of sexuality. So those of us who practice sexual health, domains of sexuality are measured by something called the FSFI, Female Sexual Function Index, and it is written erotica. It's like stories you can read. There's also another app. It's audio erotica. It's called Dipsy. So you can listen to sexy stories, and it actually increases desire. So there are lots of options. And then vibrators were presented at a major medical conference. I was shocked. They help pelvic floor health, but they also support sexual function.
Quick follow-up question about the drugs. What are the side effects?
So each drug has different side effects. So ADDY causes somnolescence or sleepiness, so it's recommended that you take it at night. You can't have more than 2 drinks with it for that very reason. It helps with mood. Otherwise, ADDY was pretty well tolerated. Vyleesi, about 30% of women experience nausea, but it gets better with each subsequent injection. And I've had women who've actually vomited or had emesis and they still want it. Because they said that their desire was so strong that it was stronger than the desire to vomit, and they hadn't felt that way in a long time. That's not how they worded it. I'm very mindful of being in a professional workspace, but they were so excited that something had finally woken up in them that they didn't care that they were puking. So,
feel dead inside.
All right.
so yes, Addie and Vailisi.
Great. We have a couple more. Did you have a question? No. What can I do about vaginal dryness?
Yeah, so I talked about some of the easier ones are, over the counter. There are moisturizers, there are lubricants, there are some Bonafide. I'm sure you guys have heard of that company, great brand that was sold through doctor's offices. They have some vaginal moisturizers. There is a procedure that we can do, radiofrequency and microneedling, that actually causes purposeful injury to the vagina that helps increase collagen, elastin, and blood flow. But I will tell you the number one thing, if you are a candidate for, which most people are just localized hormone therapy. So whether it is estrogen cream, a vaginal suppository, very, very little is actually absorbed into your bloodstream. It is even though the package insert tells you differently, and that's a whole different story with the FDA, which I've been there. But most people, even people who have gone through cancer, are candidates for localized hormone therapy, and it can help treat that vaginal dryness.
So I'm going to ask a follow-up question because it'll also go into this question. You mentioned localized, and then someone asked what are bioidentical. So can you give the definition, like what is localized and how much is absorbed, and what is bioidentical?
Okay, so when we talk about hormone therapy, there's buckets. So there's systemic, which means, we were talking about blood, so it's absorbed in your bloodstream. Then there's localized, which means it just acts in the area and a very little amount. So sometimes I tell people, like, you imagine taking a birth control pill and dividing into 365 pieces, and like one of those pieces is what actually gets into your bloodstream. Then there is bioidentical. A lot of people use that terminology to sell you something and say, well, buy my, white labeled cream because it's bioidentical. So bioidentical means it's identical to what is produced by your body. Bioidentical is in opposition with conjugated. So the drug Premarin is conjugated. They're estimated about 17 different molecules of estrogen in Premarin. And so bioidentical and conjugated are different, very different than compounded. Compounded means made for you.
All right. Any questions here? We have one more that came in virtually.
Oh, and there are FDA-approved bioidentical options, so you don't have to buy like Happy Hormone Cottages, white labeled. There is a place in Ohio called Happy Hormone Cottage.
Hopefully it'll shut down soon. Not to put anyone out of business, but that's bad business. What are treatment options for incontinence?
So pelvic floor physical therapy, whether you do it at home, whether you do it with, an exercise or a pelvic wand, surgery. So there are minimally invasive treatment options as far as a urologist or a urogynecologist will do that. Some GYNs will do that as well. But you really have to determine what type of incontinence it is. Is it happening all the time? Is it when you're running to the bathroom and urge and you're about to hit the door, the doorknob incontinence? Is it with cough, laugh, sneeze? There are medications. There are, like I said, the procedure that we do. Localized hormone
What is
can
that
help.
procedure we do? I mean, we should talk about it, or you should talk about
So
it.
there are CO2 lasers. So most women know the Mona Lisa. We had used that for a while. And now we have something that combines radio frequency, microneedling, and electrical muscle stimulation, or forces Kegels. And so basically what it's doing is strengthening the pelvic floor and thickening the walls of the vagina to help with incontinence. Most often it is FDA cleared for urge and stress incontinence. incontinence only, so not overflow. So if someone's telling you they're having to wear incontinence underwear or a diaper all the time, it's not going to work for them. And so it's not going to be an option. Those patients are either going to need medication or surgery. But that's the procedure that we do. We don't recommend it first line, but it's another tool in our toolkit because some patients are like, I don't want the medications because they can have side effect. I don't have time for surgery. I will tell you, no, almost nothing is a permanent treatment option. Even women who need or who undergo surgery may need that surgery repeated in 10 to 15 years. It really depends on the type of incontinence. So you need it worked up. And then you decide on which treatment option is best for you, depending on what you're willing to tolerate as far as downtime and side effect.
Any other questions? Oh, perfect.
So you touched on like blood testing. So can you give us, each of you or one of you, give us like what are my next steps? Like what can we do like if we want to start this journey of like examining our hormones? Like do we go to our PCB and ask for a blood test? Do we go to our OBGYN? Like what do I do now? Like, because I could like completely change my diet, completely change my exercise, but that feels like a lot. So like what little steps can I take to like start this investigation?
I would recommend going to a provider who specializes in this type of medicine. So it can be your gynecologist or it can be your GP. And I do a thorough history, physical, and workup, find out what medications you're on. And then we have a standard panel that we draw, like we call it the menopause panel. But then for each person, it changes. Like, what if it's your thyroid? Because thyroid dysfunction can present as perimenopause and menopause. What if you're losing your hair because you have a vitamin, B12 deficiency? And so we don't want to say, yes, it's definitively, your hormones. And so there's usually a standard blood panel we will add or subtract from. We draw that, and then based on that, then we can make a decision plan together. But that's a good starting point, is going to see a provider who specializes in perimenopause, menopause. And then if it is something else, then I will send that patient on to, the endocrinologist. Like if it's thyroid disease, I don't treat it as a gynecologist, but I'll get them to that specialist.
I would add getting to know your body, even tracking your cycles. So not just like how many days your cycle is, but knowing when you ovulate, looking at the length of your luteal phase. Is it 10 days? Is it less than 10 days? Is it 14 days, which is around what we consider to be healthy? Are your cycles all over the map, or are they consistent? Do you have consistent PMS symptoms versus is 1 month super wacky versus another month? These are all signs of vitality, and you can use them to inform how you would go about treating yourself or getting treatment. But I think that that's maybe a number one thing that a lot of women don't know how to do, is track their cycles.
Thank you. So as we talked about, now the stigma of talking about menopause and postpartum has lifted. We talked about the impact to women and in the workplace. What are some things employers can do to help support women during this time period?
So definitely making sure they have places to go and that they're on their benefits plan. Things like creating a room. So many patients come in and say, I wish that we had temperature controlled rooms, just like they have lactation rooms. Making sure that if you have an old male restroom, that you can convert it and make it gender neutral so that anyone can use it. Because I've been in facilities where they're like, sorry, we only have women's restrooms on the 5th floor. But I would definitely say making sure it's covered. And then educational events. We've had so many employers like this who've reached out to us saying we need to remove the stigma, taboo, and shame of being able to talk about it. And so supporting educational events like this, partnering with organizations that do offer care, and making sure their employees know where to go. And I think the other thing too is so many women fear losing their jobs if they admit that they are struggling, and making sure you're creating a culture where it is not one of fear, but rather one that you are allowing women to be brave, transparent, and authentic in their journey, and allowed to share what they're going through.
I'm going to add to that, the educational piece is also educating the men in the workplace and younger women as well in the workplace to be that support system and to understand what your colleagues are going through, to further that community feeling and to eradicate any shame or stigma, so that we have people to turn to in the workplace and everyone understands the impact that it can have on their colleagues.
I think that the other thing that maybe would be really helpful for companies is offering FSA dollars. I know many acupuncturists and pelvic PTs, physical therapists, even therapists, great therapists, that aren't offering insurance-based programming, or, they're not an insurance-based business. So having FSA and HSA dollars set aside for spending on this type of care could be really, really helpful. And then from there, the workplace culture when it comes to boundaries and flexibility, being able to work from home, things like that can make a huge difference.
I think the other thing is having a private room where we think about this for conferences, for a telehealth appointment. I can't tell you how many women have gone out to their car, have done it in a closet, like where they're trying to access because they need a private space and they wanted to be able to talk about it and they're not comfortable. But just, it would not be that hard to create telehealth rooms where people could, and they could be a dual use. They could be used as a conference, a private conference room as well, but making sure someone has that privacy so that they can engage in a telehealth appointment.
First of all, I want to say thank you. I think this is very, very informative, and it really makes me rethink a lot of experiences that we had with my mom. Struggled for many years and had horrible, dripping, like beet red, just like pouring off her shit, and kind of made me laugh. You're like, oh, women who leave their glasses in the fridge. Like, there are all these different things. And we, like, this sounds terrible. Like, it was a running joke in our house. Like, mom's losing her mind. Like, we had no idea why. Like, I just, like, feel so bad for all the time. My brother and I were just like, ha ha, right? That you don't get it. And I think this is really, yeah, and that's what all the time. She was just like, yeah, laugh now. We'll see. So it was like super, super helpful. And my first question was going to be, where is your office? I would love to share your resources with her. She lives in the Hudson Valley, so she's not far. So I didn't know if you had multiple office spaces.
Yeah, so we're in Milburn right now, and Ohio, Indiana, and Tennessee, but hopefully opening more locations in New Jersey soon.
Awesome. My personal question is, I've had multiple IUDs throughout my life, and 2 years ago, I had an OBGYN tell me that because I've had IUDs, I would probably be infertile when I decided to try to have children. Yeah. And this obviously sent me on a deep spiral, and that was awful. Found a new doctor, but in that vein, you were saying, how do you kind of plan, and you were saying about your periods and tracking your cycle, and obviously having been since I was 15 on an IUD, I don't know what that looks like. Can you speak to whether or not birth control options impact your menopausal journey, if you will? I don't know if that kind of data exists, or kind of how you navigate around that. I know that's a loaded question.
We know that fertility treatments can definitely change the age that you go into menopause. The most definitive predictor we have are when the women in your mom's journey. I'm so glad you switched the doctor. I don't think there is data on IUD impacting, because
No.
I was like, I don't think I've read that paper. I don't know where that's coming from either. With the Depo shot, we know that we can have delayed fertility for up to a year. We can. You see, I'm choosing my words, but it doesn't mean you're going to. So I don't know why they would say that to you. And sometimes some women, because the lining does get thinner, and that's one of the ways an IUD works, and that's why you may not have periods or you may not have that much heavy bleeding. So sometimes it takes a few months for that lining to build back up enough to support, a healthy healthy implantation site. But once again, you see how you're not doomed to be infertile because you've had IUD after IUD. That's the craziest thing. Well, no, that's not the craziest thing, but
Yeah, there's more crazy.
yeah, there's more crazy things I've heard, but yes, that's not true.
I think also with an IUD, when we were talking about localized versus systemic, IUD tends to be more localized. So you might actually go off it and have less of an impact when it comes to your fertility returning versus being on the pill potentially. But it's different for everybody, and the best thing for you to do is once you decide to take your IUD out is start tracking.
I know we're running out of time, so I just want to ask one follow-up question because we're for a company that largely focuses on fertility drugs, and I think you started answering the question about how fertility drugs impact your menopausal journey. Does it delay it or does it advance it?
No, so if you think about it, now I'm going to just compare. So we're born with our number of eggs that we have, and I think it's set in utero at like 6 or 7 months. I always forget like exactly when. So we're not like men where we're, making eggs. So, and then when we ovulate, we dispense them. And so this is where some people, like a gumball dispenser, like you have a certain number, and when you're done dispensing them, you're done. And so we know with fertility treatments, sometimes, right, we have super ovulation. People are, obviously, you have twins, you have triplets with fertility medications. Sometimes you're expelling more than one egg at a time. So sometimes women who've been through fertility treatments because of that may go through menopause. It may skew it a little bit earlier.
May.
Yeah, May.
With this too, we see that there are environmental factors, genetic components, even lifestyle factors that are going to impact, when you start with that transition. So that would just be one factor.
We had one more question come in. We have to, okay. How do you track cycles? Do you use an app or recommend a specific way?
I don't actually love tracking with an app because it's just an algorithm. I really love basal body temping to gain more insight into the patterns of your specific body. So basal body temping is when you track the temperature, your first temperature in the morning. That's usually the lowest temperature. It's the lowest temperature of your day.
Take me back to medical school.
It's the lowest it's your resting temperature. So in your follicular phase, before you ovulate, it's going to be a little lower, and then once you ovulate, your progesterone rises, and this creates a higher basal temperature. And so we can use that biphasic pattern to see when you're ovulating, if you're ovulating consistently around the same time, if your luteal phase is healthy. But what I generally recommend is that you get a digital thermometer and you take your temperature at the same time every morning when you wake up, before you speak and do anything, and just get a temperature read. I'm very scientific about it. I really like collecting that data and like putting it in my chart and then like seeing what's going on. And I'm like, oh, I was sick. Oh, I drank. Oh, that's why my temperature is off. But it's just an interesting way to get to know your body, and it's a fun little science experiment.
I'm an app girl. I am. It's just easy, right? Because most people have their phones with them. So tracking when they started their period, when it ended, was it heavy? Were they symptomatic? Did they have PMS? Were they moody? How many pads or tampons did they go through? Both my teenage girls love using an app. There's the Aura ring that can help. And I think there's a brand new ring coming out, and I forgot the name of it. And it's about the third of the price of the Aura. Does anyone know? And it is specifically designed to track female hormones, female health care.
Temp Drop? That's an app with a temperature, though.
It's a ring. And so I think they were launching, so that'll be coming to market as well. And then, you can also do, when we are working with people through fertility and trying to help them get pregnant, we also can draw hormonal levels to see whether or not they ovulated, pinpoint ovulation. There's also now the over-the-counter, ovulation predictors. But did you see that, is it Clear Blue Easy, they came out with the perimenopause, menopause test. I haven't seen a lot of data yet on that from patients, like in the clinical world, like how it actually works in real life. But there are multiple ways to track.
All right.
Excellent. All right.
you.
Wow, what an just amazing amount of information here. Your knowledge, your wealth, your experience, incredible. So thank you so, so much. I believe we're going to turn this over briefly to Purvi to talk about what Ferring is doing.
Okay. That was amazing. So big thank you to Callie, Dr. I'm not going to say it right. Javaid. I was adding an R. And Dr. Garner, as always, for being the Oprah for our company. So my mind is blown. I'm feeling very overwhelmed in a good way with information and armed to kind of take charge of some things that are on my mind. And I did want to just share with the group, we do have, I hope as we were going through some of the ideas that these women were sharing around things in the workplace that can help, we do have rooms around the office that you can go in to meditate, to breathe, to lie down. There's one on the second floor. And then we also have, they're not telehealth rooms, but we have small huddle rooms, right, that you can go into that are private. So you should feel free to use those for anything you need, whether it's a business call or if you have a telehealth appointment. So please feel free to access those. The other thing I will just also remind everybody of, we do have flexible spending accounts, we do have HSAs, and we do have your wellness lifestyle reimbursement account. So for things that are not covered by insurance, and if this is something, these types of things are something you want to explore, remember you get reimbursed up to $500. And if we get to 50% participation, I'm just going to plug this because I do think we want people to take charge of your wellness. And this is a great session on different ideas on how to do that. If we get to 50% participation by July 1st, we will increase the amount next year to $525 that you can get reimbursed.
Go.
Yeah.
Acupuncture all the way. Go to
Acupuncture,
HerMD.
massage. There are so many amazing things that you can try out with that benefit that we have. And then, of course, through our medical program, if you go to the Aetna website, there are quite a few resources there on women's health. So this is just a snapshot of what you'll see when you go to their site. You click through to women's health, and there's lots of different, just a wealth of information on lots of topics. So if you're charged up about this, I would suggest that you go here or go on the HerMD site or go to Callie's website.
I'm virtual based, so I don't have necessarily an office, but that's okay. You can see me over Zoom.
That's even better. And then, as Annie mentioned, we do have a part 2 of this event on women's sexual health, so more to come on that. And then in November of this year, we do want to bring some topics related to men's health, so more to come on that. And I'm just really proud that we've kind of broken through another topic at this company where we are in the business of lots of things that are maybe uncomfortable to talk about. And I just feel really proud that we have a culture here that we can talk about these things. And this is the first time I've heard certain words said in the workplace so many times that I was almost like, oh my God, I'm so old, I'm uncomfortable. But then I was like, no, this is incredible. So thank you so much. Thanks to the Wellness Committee for thinking of this and bringing this into our company. And with that, we'll close the session. Thank you all.